Hello, distinguished members of the United Nations Committee. We are delegates from the International Council of Nurses, here to talk to you about Indigenous access to healthcare. My name is Gagan Longkia, and here are my colleagues Hamdi Ali, Andrea Tudor, Christine Duong, Rosemary Gangadine, and Helen Chan. Before we begin, we would like to thank you for being able to make it to this meeting despite the coronavirus outbreak as we practice social distancing and isolation. Here is a brief presentation outline. Since we are dealing with an issue related to Indigenous populations, we thought that it would be appropriate and important to include a land acknowledgement to show our respect to the first settlers of these lands.
What does access to healthcare mean? We can view accessibility to healthcare through three definitions. The first definition looks at physical accessibility, which is the availability of clinics, hospitals, and other care centers within reasonable reach and distance of those who need it. The second is economic accessibility, in other words, affordability of these health services. Affordability can also include indirect costs such as transportation costs to health facilities or time taken off work. Importantly, affordability is based on the healthcare system of the nation and household income. Lastly, information accessibility is the right to seek, receive, and relay information pertaining to health issues. Unfortunately, we know that access to healthcare is unequal within and amongst nations. In this presentation, we will be focusing on access to healthcare by Indigenous populations, with specific examples from Canada and Australia. Before we dive into the bulk of our topic, we must also define the word Indigenous. The concept of indigeneity is complex because of the diversity of cultures, religions, languages, and histories and traditions. No single definition can really capture the characteristics of an Indigenous population, but for the purpose of this presentation, we will be referring to the WHO definition. So, Indigenous includes people who have a historical continuity with pre-invasion societies. They identify themselves and are recognized by their community as Indigenous. They have strong links to the territories that they inhabit. They have distinct social, economic, and political systems, and they maintain their distinct languages, cultures, beliefs, and traditions. They form a non-dominant group of society, and they resolve to maintain and reproduce their ancestral environments and systems as distinctive peoples and communities. We would also like to preface that Indigenous people inhabit almost every corner of the world. The largest populations are found in China, India, and Russian Siberia. However, most of the accessible scientific information or reports on Indigenous people come from Western countries, notably Australia, Canada, New Zealand, and the US. As previously mentioned, we will be focusing on Canada and Australia.
Let's take a moment to discuss the general health of Indigenous people. There are great discrepancies seen between Indigenous people and their non-Indigenous counterparts. In Australia, the reported gap in life expectancy between these two groups is 10 years. Although this statistic is specific to Australia, similar gaps do exist in other countries such as New Zealand, Canada, and the United States. The reason for these discrepancies and the issues that Indigenous people are left to face are multifactorial and long-standing. The mortality and morbidity rates are higher among Indigenous communities, making their average life expectancy lower than their non-Indigenous counterparts. Indigenous people also show higher incidences of mental health issues and lower access to appropriate care, despite studies showing that there is greater willingness among this population than the general population to seek mental health care. As we discuss access to healthcare, it is important to note that access is not only about getting to the care, but it is also about how services are delivered at the point of care. This care must be necessary and appropriate, which is not always the case for Indigenous people. In order to discuss access to healthcare, we have to consider post-colonialism, as the two are intertwined. We have to acknowledge how colonization has shaped the way that Indigenous people define and relate to their homelands and several social systems, based on ideas of race, status, and more. Indigenous people have always been placed into a category of other, as they fall into the margins of society. Colonization has decentered all that do not reflect the idea of a white man, and this tends to be the starting point for comparison that makes everyone else less than this image. Intersectionality is the voice of the marginalized and is a lens that helps us critically reflect on our assumptions by disrupting and reflecting on this construct of the quote-unquote other. In Canada, healthcare services are labeled as universal to all citizens under the Healthcare Act, and the system is labeled to be one of the best in the world. Under the Healthcare Act, access is defined as equitable distribution of services to those in need for the common good and health of all residents. Yet, all Canadians don't have equal access to these services. Canada ranks number 6 on the Human Development Index, which is a measurement of achievements in key dimensions of human development such as life expectancy, education, and standard of living. On this same scale, Indigenous people in Canada rank 68. These inequities are rooted not only in historical colonial policies and legislation, but they're also perpetrated by barriers to accessing healthcare. Some of these barriers include racism, discrimination, intimidation, and harassment. Additional barriers include inequitable federal funding for health and social services for Indigenous people living on reserve, a failure to address gaps in services, as well as a lack of cultural safety. Indigenous communities are also impeded by legislative confusion, and one of the contributing factors to this is a lack of clear government accountability and historical arguments between provinces and federal governments over who is responsible for providing and paying for healthcare services for Indigenous people. Although health support for Indigenous people is seen as a federal government responsibility, as outlined in the Indian Act. As we begin to discuss Indigenous Australians, it is important to note that many of the issues faced by Indigenous Canadians are also applicable to Australians and vice versa. On average, Indigenous Australians are younger than their non-Indigenous counterparts, with a median age of 21 versus 37. They are found to have a significantly lower life expectancy and face proportionately greater challenges in terms of a variety of indicators such as socioeconomic status, physical health, and mental health. Indigenous mothers in Australia are significantly less likely than non-Indigenous mothers to use a range of healthcare services, including visiting maternal and child health centers, general practitioners, and pediatricians. Reasons for this access barrier include a lack of healthcare insurance coverage, socioeconomic disadvantages, cultural traditions, lack of available resources, language barriers, and transportation issues. A national health survey in Australia revealed that Indigenous children are most likely to have unmet health needs. The most frequent unmet need found within the survey was a lack of accessible primary healthcare services, and these disparities mirror socioeconomic status, employment, education, insurance status, and environmental differences.
How has globalization influenced Indigenous access to healthcare? Well, we know that globalization and free trade led to the exploitation of resources, which has had detrimental effects on the environment. Pollution, the increase in greenhouse gases, and rising global temperatures are affecting the most vulnerable groups, which are Indigenous communities. Climate change has both direct and indirect effects on the health and access to Indigenous people. For example, in the circumpolar north, Inuit communities are greatly affected by rising temperatures, decreased snow and ice quality, and altered wildlife and vegetation patterns. These conditions are impeding Inuit from participating in hunting, harvesting, and fishing, which are important in sustaining well-being, knowledge sharing, and cultural continuity. If they can't rely on their traditional foods, they might turn to fast foods or other things, which will lead to a decrease in health. Similar to the previous example, colonization directly resulted in the loss of ancestral land and resources, which in turn led to a change in diet and physical activity, which has generationally been attributed to higher rates of obesity and related disorders like diabetes and cardiovascular disease. Colonization led to forced assimilation of Eurocentric values. So, for example, children in Canada were taken away from their homes and forced into residential schools far from their families. Similarly, in Australia, the stolen generation refers to children who were taken from their homes from around 1910 to the 1970s. This caused intergenerational trauma that has had lasting effects to their present-day physical and mental health. During these times, Indigenous people were also banned from many cultural practices, such as traditional medicine and healing, and eventually, the dominant language on the land became one of the colonizers. You can see how this has affected healthcare today, because if there are language barriers, this directly affects access to healthcare when the Indigenous people cannot speak with healthcare practitioners.
When Indigenous people try to access healthcare. There is an assumption that the access to healthcare is similar to settlers' quality of access. For example, when we access healthcare services, our cultural values are often reflected upon care. We can expect in Toronto to have our cultural values and beliefs respected and be able to acquire culturally specific support due to hospitals' strong determination to deliver culturally appropriate care. However, this is often not the case for Indigenous people here in Canada, as they continue to be treated as second-class citizens due to structural racism and lingering colonial experiences. Colonialism and power inequities influences the quality of delivery of services at the point of care. Particularly, we're talking about the social relationship between the provider and the patient, that is needed to create the trust and respect to provide optimal care to the patient. However, in the two countries that we looked at, we noticed that Indigenous patients still tended to have negative experiences with healthcare services and healthcare providers due to the lasting effects of structural racism subtly designed to maintain the power dominance relationship. Access to healthcare can also be further hindered unintentionally, as Horae noted. For example, the geographic distance and the corresponding cost to transportation it decreases the availability and retention of healthcare providers, leading to long wait lists and causing limited access to screening and, most importantly, preventative services. Coupled with the fact that Indigenous people tend to have lower education compared to the non-Indigenous peers, these unintentional barriers can have devastating consequences, as low education can result in the lack of awareness of the importance for early detection and preventative care. While basic services may be covered by the government, so-called elective yet essential healthcare, such as dentistry, creates financial barriers, further preventing Indigenous people from accessing healthcare. Because they are less likely to access healthcare, DeJoy in 2018 noted that Indigenous Africans, just like Indigenous people in Canada, are more likely to experience low social determinants of health. For example, they are less likely to access social services which are designed by non-Indigenous governments for Indigenous people, and are at more at risk of being poorly educated due to chronic health, and are at a higher risk for poverty due to the forced migration limiting their access to the traditional economy. Although modern governments are now recognizing that Indigenous groups should be given the autonomy to decide their own care, new policies still create barriers, perpetuating unequal power relationships that are continually shaped by subconscious racializing influences. Key determinants of Indigenous health all around the world, including Canada, such as racism, cultural identity, are really identified during the policy creation cycle. This lack of insight becomes obvious when the proposed policies deals with identifying and determining who's in charge of running healthcare programs for the Indigenous population. To give you an example, in Canada, healthcare services for Indigenous individuals are still highly fragmented. Indigenous people still experience different levels of access based on the Indigenous person's classification, full status, Métis, Inuit, off-reserve, non-status Indian, and the level of government they are seeking healthcare from. Currently, Indigenous healthcare services are split between federal, provincial, and local Indigenous council bands, and each system has different eligibility criteria. Healthcare systems in Canada are usually created by individuals who are not part of any Indigenous groups. As a result, Indigenous bands in Canada are currently fighting for more consolidated healthcare, as they believe that having all healthcare services within their control would best serve their needs.
Before we discuss the implications of global health inequities on access to healthcare, we must understand the difference between equality and equity. According to the WHO, equity is the absence of avoidable or remediable differences among groups of people, whether those groups are defined socially, economically, demographically, or geographically. Equity is a process, and equality is an outcome of that process. Achieving equity will not be accomplished through treating everyone equally. It's achieved by treating everyone justly and according to their circumstances. Knowing the difference between health equity and health equality is important to public health because it ensures that resources are allocated appropriately. Nurses and other healthcare workers also must support the ongoing process of meeting people where they are. To reduce the health disparities gap, the fundamental issues and individual needs of vulnerable populations must effectively be addressed. The world's global structure, where governance, trade, and economics are informed by neoliberal globalization. Consequently, decision-making and national policies are subject to global influences. These influences include the emergence of the World Bank becoming a major player in health governance in the 1980s. A growing emphasis on global trade and international relations has impacted health
in different ways across countries, thus has led to the World Trade Organization to have a key role in regional and bilateral trade agreements. Private foundations such as the Bill and Melinda Gates Foundation entering public and private partnerships have become major players in global health issues, and the WHO's erosion of legitimacy as the leading organization on global health. This has shifted global governance for health away from intergovernmental forums. As the wealth and health disparity gap expands, we see inequitable race relations where groups who claim racial superiority at the expense of those deemed inferior. Racialized biology produces and justifies the categories that have formed hierarchical racial and ethnic groups. This in turn generates inequitable living and working conditions that embody the biological expression of racism. Some examples of implications of health inequity include economic and social deprivation, excess exposure to toxins, hazards, and pathogens, social trauma, health-harming responses to discrimination like drug, alcohol, or tobacco use to alleviate stress, inadequate medical care, targeted marketing of harmful commodities such as placing liquor stores, fast food restaurants, and gun shops in predominantly African American neighborhoods, and especially for the indigenous peoples of the world, ecosystem degradation and alienation from the land. We argue that investing time and effort in global health equity will reduce the negative impacts of the social determinants of health like better housing, living, and working conditions, safer schools, improvements in social networks, and the inclusion of political rights and freedoms when policymakers discuss legislation. Global health equity will in turn provide more opportunities to obtain and maintain good health and avoid illness. Expansions to promote health literacy will decrease negative coping mechanisms that will be replaced with more positive ones. There will be a reduction of social stratification for groups like women, children, low or middle income individuals, people with disabilities, or racial ethnic groups, thus providing more economic and social opportunities to those vulnerable populations as listed before.
We're going to look at international policy responses that can address this topic. In 2007, the UN developed an important standard entitled the UN Declaration on the Rights of Indigenous People. In Article 24, they state that Indigenous people have the right to the highest attainable standard of physical and mental health. They also affirm that Indigenous people have the right to enjoyment of socioeconomic rights, including water, sanitation, and health, and that governments shall ensure that adequate health services are available to the people concerned. The WHO also mandates protecting Indigenous rights to optimal standards of health globally. With these declarations in mind, we would like to introduce additional international standards for addressing inequities in Indigenous healthcare accessibility. One initiative is decolonizing medicine and healthcare systems, while simultaneously promoting cultural competent care and safety training. An example of decolonizing medicine is actually occurring in Hawaii, where the Office of Hawaiian Affairs is backing a bill promoting native concepts of well-being, culturally grounded in traditional healing and health practices. This was a governmental response to findings that colonized styles of Western healthcare did not meet the mental health needs of Indigenous people in Hawaii. The bill states that health programs and services that are aligned with Native Hawaiian cultural identity, values, and beliefs can significantly increase the number of Native Hawaiians who utilize mental health services. In addition, there needs to be a requirement in improving professional awareness and cultural sensitivity around Indigenous systems of healing. We should move towards medical pluralism, the awareness that Western medical practices is really just one of many global healing systems. To throw light on this unconscious bias, healthcare providers, such as medical and nursing students, should have basic knowledge of medical anthropology, including Indigenous history, and this should be done by incorporating it in the core curriculum of schools. Finally, we mentioned at the beginning of our presentation that Indigenous people are greatly affected by climate change. For populations that are experiencing these effects, such as Indigenous communities in the North, we propose creating an integrated Indigenous-led environment and health monitoring systems. By creating policies that call for Indigenous-led assessment, planning, implementation, and evaluation, communities can identify their own priorities and plans of action, which could then influence policy, all the while restoring their right to self-govern. For use of Indigenous lands, we need to acknowledge that consultation by governments with Indigenous communities to use these resources should be seen as a right and a necessity, not a favor.
So here are some of the policies that we're proposing at the national level. And at first we will be discussing the specific policies for Canada and then for Canada and Australia. For the first point, we see that there's a lack of criteria for determining who is considered Indigenous in the Canadian legislature. This is an issue because a lot of Indigenous individuals are being excluded from consideration in policies, even though they have endured the hardships of being an Indigenous individual and continue to endure these to this day. But specifically, as seen on this slide, the diagram, this diagram is showing the Canada second generation cutoff rule, where if there's two generations of a parent that is non-Indian, after two generations, the individual loses their Indian status. So this, we believe, is a problematic practice, and we propose that this practice be changed or eliminated altogether. Furthermore, it seems a bit inappropriate for the Canadian government to have the sole say in determining who is and who isn't legitimately Indigenous. We believe that this practice should include the voices of Indigenous communities in determining a criteria for determining Indigenous status. So the next policy we have is looking at fixing the gaps and ambiguities that are present in the federal and the provincial and territorial legislature. So this was based on the article by Jose Lavoie, where the author attempts to answer if what we have in Canada is an Aboriginal health policy patchwork that fails to address inequities, then what would a healthy Aboriginal health policy framework look like? So essentially, we're saying that there's a discrepancy in terms of federal versus provincial and territorial jurisdiction. So the federal government is responsible for providing certain amount of care to Aboriginal individuals to improve their health, but this was quote unquote thin and loosely woven. So the federal care is not comprehensive, and whatever is not provided, the federal government expects the provinces and territories to make up for the care difference. However, there's a variation in this among different provinces and territories across the country, where some may provide care to Aboriginals while others don't at all. So we would propose that a specific legislation be in place at the federal and provincial level where Indigenous populations are properly covered in terms of the healthcare that they're receiving, and it's not just the federal government kind of hoping that the provincial and territorial governments will take care of the population, or the provincial and territorial governments hoping that, oh no, it's not our responsibility, it's the federal government's responsibility. And the last point that we have here is reducing stigma via education. So some of us may remember learning about Indigenous history in schools, but this is not the case all across Canada. There are some provinces that are including this in their primary curriculum, while there's other provinces that are completely excluding this from their education system. So we would propose that in order to prevent general stigma and increasing awareness for Indigenous communities, we should be incorporating this through the primary school curriculum. So on this slide, we have the policy proposal that we're making to Canada and Australia because they do have some similar issues in this case. So we propose that there be legislation in place that ensure that Indigenous individuals are more involved in councils that are allocating and managing health resources. So there should be a sort of community-centered approach here where the people that are being served are leaders in their own health. So there should be policies in place that encourage power and autonomy for Indigenous groups by providing leadership opportunities and including them in the decision-making process. So it's not really some outsider coming in and trying to make these changes. We should be looking at the views of what the Indigenous individuals feel would be most effective and then basically collaborating with them to improve the Indigenous health outcomes. So next we have a more of a sort of general upstream approach here where we're encouraging funding for technology for remote access to care areas. So especially in both these countries, there are a lot of remote areas where Indigenous populations live that do not have great access to healthcare. So there's like high prevalence of diseases like HIV, tuberculosis, and type 2 diabetes in these Indigenous populations. And by funding technology, we can address these, like having drones that provide urgent medical supplies, or self-test kits, or even mobile health via apps and tech services. And this will help improve compliance of therapy, identify diseases that may be present with more sensitivity, specificity, and speed, so that in case these individuals are not able to go to a health clinic, they are able to take their health in their own hands, are able to work even from a remote setting. And similarly, infrastructural changes are very similar to servicing remote areas, where we are encouraging for the building of more roads, public transportation, better highway lighting, medical transportation, and so on, so that these obstacles can be overcome by remote Indigenous communities in these countries. So we all know at the moment that COVID-19 is a big threat, and this has been an issue for remote regions in Canada and Australia, where we're really starting to see the inadequacy of the healthcare system for these remote regions. So in both countries, Indigenous populations in rural areas are deemed more vulnerable to the virus due to overcrowding and little access to hospitals. So we've seen Prime Minister Trudeau that he's reassured Indigenous leaders that they will provide federal funding for Indigenous communities to fight COVID-19. And in terms of Australia, Australian officials are regulating movement in and out of the remote regions, and the National Aboriginal Community Controlled Health Organization is stating that the army should be deployed to these remote regions to contain any outbreaks and to even bring any shortage of supplies, because there is a shortage of equipment for remote area health workers. So these are very, again, reactive policies and actions in something that's an emergency right now. And we believe that the policies that we're proposing could have prevented this from happening if this sort of upstream approach had been taken earlier on. And finally, we're including a policy that would educate and advocate for healthcare providers to use culturally competent care. So once again, this is a more upstream approach where these healthcare providers are more culturally competent and are practicing cultural safety. And this can be done by mandating Indigenous education in the healthcare curriculum. In fact, we can even go as far as Indigenous individuals being incentivized to become healthcare providers in their communities by adapting schools to be more Indigenous friendly and having more nursing and medical schools located near Indigenous communities with seats that are dedicated to Indigenous students. So again, in both of these countries, there was a sort of sense of Indigenous individuals feeling discrimination or racism from healthcare providers, which would impact the therapeutic relationship. So by educating healthcare providers in cultural safety and culturally competent care, we would be using an upstream approach to improve health outcomes for Indigenous individuals.
Whether from Indigenous or settler societies, nurses are the liaison between individual and community health and the factors affecting one's holistic or overall health. Indigenous health is viewed holistically and can be affected socially via the social determinants of health, physiologically through acute to chronic disease or injury, spiritually or mentally and emotionally. As the largest healthcare profession in Canada, it is the responsibility of nurses to address post-colonialism and the resulting health inequities. This can be done through actively working to deconstruct stigma, supporting evidence-based research, practice, and interventions, as well as by advocating for the expansion of services to address Indigenous needs with Indigenous people. In doing so, nurses would be actively working towards taking an upstream approach in the provision of client-centered care, promoting reconciliation and opportunities for empowerment and leadership within Indigenous communities. As individuals, nurses can build therapeutic relationships with Indigenous individuals by listening to their needs to see the individual as a whole, understand their perspectives, increase individual participation, and establish respectful, trusting relationships that are the seeds of which self-determination and empowerment can grow. These relationships can further flourish by creating caring, healing relationships with communities, hereditary and elected chiefs, while establishing partnerships to focus on addressing Indigenous needs. Additionally, when encountering prejudice and stereotypes, individual nurses can use their knowledge and competence to assess statements, actions, or behaviors, plan on how to address them, intervene, and later evaluate to reflect on these interactions and how they shape our public ways of knowing. Individuals can also carry on the legacy of Shannon's dream and Jordan's principle by advocating for the clear provision of services to avoid inequities in basic quality of life without children having to die to prove a point. Nurses can also advocate against the second-generation cutoff rule, keep informed on the current political and social climate, monitor initiatives for their results and outcomes, as well as exercise one's right to vote. As the most trusted profession and the largest group of healthcare workers in Canada, the profession of nurses can work with local, national, and international Indigenous and non-Indigenous nursing organizations, such as the International Council of Nurses, Australian Nurses and Midwifery Federation, the Canadian Nurses Association, and the Canadian Indigenous Nurses Association, to, as the Canadian Nurses Association says, raise awareness of the root causes of inequality in global health and participate in finding solutions. Using this stance, it is vital nurses and their organizations work together to enact change. Due to the size of local, provincial, federal, and international nursing organizations and the specific issues that some Indigenous groups face that others may not, the profession of nursing could lobby, suggest, and advocate for the following: push for outcomes-based measures to address the current inability to obtain safe, accessible resources, push to incorporate and teach Indigenous perspectives in history versus the current Eurocentric ones in school curriculums from junior kindergarten to grade 12 in order to fight stigma and create awareness of the impact of colonization, campaigns to address current health disparities as a result of the social determinants of health and the impact of Western lifestyles and medicine on one's ability to self-determine, push for the expansion of culturally safe healthcare access centers, incentivize Indigenous people to pursue nursing and create positions that allow them to work with their communities to provide atraumatic, culturally relevant care, as only currently 3% of all registered nurses in Canada identify as Indigenous, support and fund research to promote evidence-based assessment, planning, interventions, and evaluations that are culturally relevant to Indigenous communities, commitment to long-lasting protective interventions to achieve the Sustainable Development Goals for low and middle-income Indigenous people in Canada, and to develop sustainable primary, secondary, and tertiary prevention programs and interventions for Indigenous people that provide education that is culturally relevant. Access to healthcare is often thought of as an issue affecting developing nations. However, in our presentation, we wanted to highlight the struggles faced by Canadian and Australian Indigenous peoples. And lastly, nurses have an important role as the most trusted profession and the largest group of healthcare providers in Canada to take action as individuals and as a profession to dismantle oppressive structures to empower Indigenous self-determination.
Thank you all for taking the time to listen. We wish you good health and hope that we can contain this pandemic as soon as possible and as efficiently as possible.